Thank you. Just to comment a little more about what Dr. Arousal said as far as compounding pharmacies. I can't impress upon you enough how important that is, that the person who is mixing up your compounds knows exactly what they're doing. I have had horror stories from patients who, unfortunately, some of their insurances require them to go to a specific compound pharmacy, or some of them think that they're going to save money by going to a Walgreens or CVS that says they do compounding. It doesn't really work that way. You have to think about compounding pharmacists are very much like master chefs. I mean, we can all look at, Emerald's or Leo Lugassi's recipes and think we can make the same thing, but the truth is, it's not going to come out the same way they do, because they're experts at how to mix things and how to make. And you got to think about the compounding pharmacists that way. They are truly experts in what they do. This is a little different than what we've done before. A lot of the talks I've done before have been on menopause and hormones. We haven't really focused specifically on female sexual dysfunction. And so that's what we're about today. And when it comes down to it, what we're really talking about is, the best way to define it is the difficulty or the inability of a woman to find satisfaction in sexual expression. And it's a huge problem. It affects women more than men, despite what you think. You look at 43% of women in surveys have issues with sexual dysfunction versus 30% of men. So that really comes down to about 40 million American women. And although it increases with age, it can occur at any decade of life. I have women in their 20s who have issues with sexual dysfunction. So, how big a problem is it? I think all of you can pretty much guess anytime you go through the grocery store, you're going to find sexual issues on the front of every Cosmo magazine. It is amazing. I'd like to know who has the job of coming up with these things, writing these articles. And if you think it's confined to the US, it isn't. This is Russia, this is Spain, this is Korea. So no matter where you look up Cosmo, anywhere in the world, you're going to find issues with sexual dysfunction on their covers. It comes down to we've broken it down scientifically into 4 different categories. Women would come to me and tell me that they had problems with their libido. And they never really understood exactly what their problems were, because when they talk about libido, they kind of lump everything involving problems with sex as libido. And it's a lot more than just that. Hypoactive sexual desire really is problems with decreased libido. And that comes down to a lack of sexual thoughts, lack of receptivity to sexual activity. Then you have issues with arousal. And that's a recurring inability to achieve or maintain sexual excitement. There are issues with orgasms. And it's a chronic difficulty, a delay, an absence in never achieving orgasm following sufficient sexual stimulation and arousal. And sufficient is critical there. And then there are a whole multitude of pain disorders that we'll get into. A lot of what we see in our office, issues with sexual dysfunction, do come down to pain problems. And it really comes down to, it's a big, broad thing. Any diagnosis that results in insufficient pain so that sex is uncomfortable or impossible or just not enjoyable. Dyspareunia is actually having vaginal pain with intercourse. Then there's issues called vaginismus, which is actually an involuntary spasm of the vaginal muscles that creates so much tightness that they're unable to have vaginal penetration. And then there are patients that have sexual pain even when they're stimulated elsewhere. They can be kissed, they can be stimulated on their breasts, and they develop pelvic pain. So what's a normal sexual response? It begins with the stimulation of the major sex organ of the body. Anybody want to chime in and tell me what it is?
Brain.
I'm sorry?
The brain.
Exactly. That's where everything starts. And somebody offered me a slide of what, that was the female brain. This is really what the male brain looks like. So there are both electrical impulses through the nervous system as well as chemical signals that go from the brain to the organs of the pelvis. You're increasing blood flow, which is doing a lot of things. It is increasing, it's stimulating the glands, so you're creating lubrication. It's relaxing the smooth muscles of the vagina so that the vagina actually becomes wider and deeper. Both the nervous stimuli and the biochemical reactions will also cause stimulation of the clitoris. So it's actually increasing in length and becoming engorged, and engorgement of the labia as well further increases the blood flow of the clitoris. There are a whole raft of medical problems that can affect female sexual dysfunction. Problems with vascular disease, because it decreases the blood flow. If it decreases the blood flow elsewhere in the body, it will also decrease the blood flow to the pelvic organs, which creates issues with arousal and even absence of orgasms. Diabetes, especially women who have developed diabetes that affects the nervous system, because that's going to impact transmission of those signals from the brain to the genital. Arthritis. Some women develop just horrendous problems with arthritis to the point where there is not a comfortable position that they can get in where they can actually enjoy sex. Look at cardiovascular problems, high blood pressure, coronary artery disease, heart attacks, peripheral vascular disease. The list is pretty endless. Cancers of the intestinal tract, irritable bowel is a problem. Women that end up with colostomies have psychological issues that go along with that as well. Neurologic problems, multiple sclerosis, people that have had paralysis, strokes, and again, issues that affect the peripheral nervous system. Fibromyalgia, arthritis, autoimmune disorders. Endocrine problems include diabetes, thyroid problems, adrenal problems. Prolactinomas is an interesting one. Prolactinoma is a very small tumor in the brain that affects a part of the brain that normally secretes something called prolactin. And prolactin is the hormone that's secreted while women are breastfeeding, and it's designed to pretty much shut off the production of eggs, which is why women typically don't get pregnant while they're breastfeeding. Well, prolactinomas will actually not only obviously shut off egg production, they will also shut off libido as well. And then psychological causes, which is probably the hardest to deal with and some of the most common ones we see. Depression, problems with a lot of interpersonal conflicts. It's not necessarily problems with their husband. There's a lot of problems, especially these days, where I have a lot of patients who are dealing not only with adult-dependent children that have moved back in the house, they're kind of sandwiched in between because they're also dealing with elderly parents that they have to take care of, that have to live with them. A lot of times it comes down to actually just physical and mental exhaustion. They've got so much else going on in their lives that they really have no time to really deal with enjoying sex. Gynecologic problems obviously are a huge part of this. A lot of women don't think about this, but when you have defects in the vagina, that will create painful issues. Cystoceles and rectoceles basically are hernias. Cystocele is a hernia of the bladder into the vagina, rectocele is a hernia of the rectum into the vagina. Problems all start with damage from childbirth, and then age and gravity set in. And typically, when you get a cystocele and the bladder drops, women develop pressure. They have difficulty completely emptying their bladders. When they have rectoceles, they develop constipation issues. They develop looseness with intercourse. Some of them get to the point where they actually have to put a finger in the vagina to push the rectocele down so that they can have a bowel movement. But these defects also narrow the vagina so that with penetration, sometimes they'll actually feel like there's something there blocking entrance into the vagina and creates a lot of discomfort. There are a whole variety of problems on the vulva where it becomes so sensitive or irritated that it's uncomfortable. Uterine prolapse, when the uterus itself drops. The uterus normally sits at the very top of the vagina, but when the uterus starts to drop, again starting with childbirth and then age and gravity, and if it's dropped into a third or even halfway into the vagina, you suddenly have lost half the length of the vagina in which to enjoy sex. So patients will, if you ask them, they'll suddenly start to notice that, yeah, if it does feel like he's hitting something with penetration. Vestibulitis is actually a problem right at the opening to the vagina where the tissues are incredibly sensitive and painful. The vestibule is just the area right outside the entrance into the vagina. Those tissues are a little different than other tissues on the outside of the body, and they can unfortunately become incredibly painful for some women. There are actually some women where you actually have to go in and actually excise that tissue in order for them to be able to have intercourse. Vaginal vault prolapse is very similar to what we talked about before as far as the uterus dropping. Only this is the vagina itself turning inside out with someone who's had a hysterectomy. Vaginismus is, we talked about that a little bit already. It has to do with the muscles contracting prematurely, creating discomfort. Vaginal atrophy happens to primarily women who are menopausal, where they have run out of hormone or they don't have as much hormone as they did before. The tissues of the vagina are the most sensitive in the body to lack of estrogen. So if you don't have enough estrogen in your system, the tissues get thinned out. They in essence become sort of raw. They do not have enough estrogen in order to dilate properly, so that you lose the elasticity you should have. You lose the lubrication. It's a huge problem as far as intercourse is concerned. I can tell you that when Viagra came out on the market, we had an incredible influx of women because suddenly, their husbands who were not having sex before, are now able to have sex, and suddenly these women are coming in because they're incredibly uncomfortable with intercourse now. It's one of the easier problems to fix. Even for women who are deathly afraid of ever taking a hormone, the estrogen that you put in the vagina does not get into your body. The dosages we use are designed to function only in the vagina, and it's not going to get absorbed into the system. It's so safe that our patients who have ongoing breast cancers can use it. Uterine fibroids. Fibroid tumors are benign tumors of the uterus. However, they can be in the wrong position, they can grow to be a large size, and that will create a very large mass that will again create discomfort with intercourse where they'll feel like the penis is hitting up against something. Episiotomy scars and scars just from tearing with childbirth. The scars, the tissue that has been cut or has torn with childbirth, is obviously not as normal as it was before it ever got cut. So a lot of women do have discomfort right in the scarring. Pelvic inflammatory disease, infections can obviously also cause scarring and create discomfort. Simple vaginal infections sometimes are the issue, and that's one of the easier things to take care of. Endometriosis in women create enough scarring where again we have issues with pain. By the time we see most of these patients, they're menopausal, but the damage was probably already done from endometriosis.
Lichen sclerosis happens to be a thinning out of the of the vulvar tissues, and the tissues become so thin that they are incredibly painful and itch a lot. It's impossible for some women even to wear underwear. And obviously cancers. Interstitial cystitis is a huge problem. And one of the more common problems we see when we're dealing with sexual dysfunction and pain in women. There are problems with the bladder in which women find themselves with painful urination. They have issues where they're urinating frequently. They're getting up several times during the night. And a lot of times they will go to an urgent care center to their family doctor and they get treated for a bladder infection. The problem isn't the bladder infection. They have interstitial cystitis. There's actually, I think in your folders there is a checkoff list. If you have any of those symptoms and you want to check it off, you can look at it, and then Joe in the back will be glad to go over it with you. And adhesions to the clitoris, which we see on occasion in women who've had very difficult births or they've had a lot of tearing. Medications. There are tons of medications that will impact sexual function, impact libido, impact ability to be aroused, impact orgasms. It has to do with antidepressants, street drugs, a whole bunch of different things. I threw up a list of just some of the more common ones, but there are an awful lot out there, and there are an awful lot of women that are on a variety of these drugs for a lot of different reasons. But for some women, many of these will indeed impact your ability to reach an orgasm, your ability to even desire sex. We evaluate our patients with a physical examination, obviously. And it's a very careful inspection and evaluation of the pelvic organs. A lot more than just a simple pelvic examination. We go through it step by step, trying to isolate exactly what the issues are. We're looking at the external genitalia. We're looking for the inside of the vagina for defects, for muscle tone. We're looking for the atrophy of the tissues. We're looking for scarring, lacerations. We're also looking to see if there's any problems with the uterus, the ovaries, or even the rectum. And then we do a careful pain mapping. Jill, did you bring the... Oh, we didn't bring the pain map. Yeah. We actually have a diagram where primarily it's usually Jill that will sit down with the patient and with a Q-tip go point by point by point, trying to isolate exactly where the pain problems are. And then basic laboratory studies. We're going to definitely look at their FSH levels, which is going to tell me whether indeed they're menopausal. We want to know what their estrogen level is. We're looking at their testosterone levels. Something called sex hormone binding globulins. The sex hormone binding globulins, unfortunately, will, if you have high levels, they're going to trap the sex hormones, and if they basically kind of keep them from getting to where they need to be. So women who have high sex hormone binding globulins don't have enough free hormone to actually function. So that's why we very carefully look at what the free testosterone level is, because that's what we want to know about, is how much of the testosterone, it doesn't really matter how much total testosterone a woman has, how much of it is really available for the pelvic organs to use. And we look at thyroid. Thyroid is a really big problem when it comes to women, menopausal women. It has to do with energy level, it has to do with libido, it has to do with controlling your weight. And that's probably something I hear from probably 2/3 of my patients every day. If you have ever had your thyroid checked, everyone starts off by checking something called the TSH level, thyroid stimulating hormone. And I will guarantee that most of you will probably be told it's entirely normal, and it isn't. The normal range for a TSH for most laboratories goes from 0.5 all the way to 5.0. It is a huge normal range. I will also tell you that after doing this for 30 years, that women who have a TSH level that is above 2, still in the normal range, but if it's above 2, they are not feeling as well. They very often have issues with fatigue and with sexual desire, but more importantly, their metabolism is very difficult to, it makes it very difficult for them to control their weight. And I mean, we have enough issues with our metabolism as we get older anyway. The add thyroid on top of it just, makes it an impossible situation for them. So, if you ever have your TSH level drawn, make sure you ask for what the number is. Because if it's over 2, it probably definitely could stand to be spiffed up a little bit. And prolactin levels. I talked a little bit about the prolactin secreting tumors in the brain that can cause libido issues. So, when we talk about hypoactive sexual desire, that's actually the libido problem. That's where your desire has dropped off. There are, and I have this discussion where we'll go into details with women about what their desire is now versus what it was several years ago. Most of the time, the issue really is hormonal. It comes down to estrogen and testosterone. And it's not just testosterone. Even though testosterone in women is primarily responsible for sex drive and for energy level, if you do not have adequate levels of estrogen, testosterone doesn't work. So it's really important that we build up the estrogen level as well. And that's one of the things actually I start with, is I'm going to work on building up a woman's estrogen level first, and once I get the estrogen level where I want it, then we're going to start adding some testosterone. But when you talk about libido issues, there's a whole myriad of other things that come into play. None of this is medical, but it definitely affects it definitely impacts having sex, whether you're going to find time to have sex, whether you're going to be able to enjoy it. When you look at hormones, estrogen is very helpful in both premenopausal and postmenopausal women. I have women who are not yet menopausal where I'm adding a little bit of estrogen and they're feeling better. I know I get patients that have been to other doctors who said, oh, well, you're not menopausal, you don't need anything, go home. But there are some women where adding a little bit of extra estrogen is going to be beneficial. We are very careful about when we track hormone levels because it does make a difference. One of the things we do in our premenopausal patients is we're going to track their hormones on the second or third day of their cycle, which is going to be when their estrogen level is going to be the lowest. And we're also going to track it on the 21st day of their cycle where it's going to be the highest. And there are some patients who've been seen elsewhere where they just get randomly drawn during their cycle, and that's kind of a meaningless number. Testosterone definitely seems to work on libido, so we're big proponents, but you got to be careful with it. There are no commercially available levels of testosterone compounds that you can get. There are male levels, and I've had patients they've tried to take an androgel pack for a man and try and break it up over 4 days. That's really hard to do. So we find it much more efficient and much safer for the patients to have it compounded. And that's where Dr. Lee and I work very carefully in making sure that we get adequate levels of testosterone. We don't want to overdo it. Because part of the downside, if you're going to overdo it, is there are some risks to getting acne. There are risks to getting excess hair growth that you don't want. Things such as deepening of the voice, hoarseness, I haven't seen that in years. So that's really not an issue. But mostly the things that I'm going to see from women are going to be acne or hair growth if the testosterone level is way too high. And you also will see aggressiveness too, if you've got too much testosterone in the system. Progesterone, we use progesterone to balance out estrogen in women who've not had a hysterectomy. But one of the downsides of progesterone, unfortunately, is it can dampen libido. So we have to be a little bit careful with our patients that need progesterone. Sexual arousal disorders, some of them have to do with atrophy. A lot of it has to do with inadequate stimulation, anxiety issues. it's probably one of the harder things to deal with. We talk about foreplay, we talk about relaxation, estrogen replacement. There are some small studies now that are showing that possibly adding Viagra or Cialis makes a difference. But this is probably the hardest one for us to deal with. Believe it or not, there are a lot of women out there who do have issues with orgasms. These actually respond pretty well to therapy. Things such as fantasies to decrease your inhibitions, background music, masturbation, use of vibrators. There are pelvic muscle exercises to help muscle control and relieve sexual tension. Kind of a side effect of the pelvic muscle exercises that we have been doing with our incontinent patients, it turned out that one of the side effects was indeed that women were having much more success with reaching orgasms, which kind of led to the intensity device. Intensity is designed as a female sexual health device to give women who have sexual dysfunction, the ability to reach vaginal orgasms. It was kind of an offshoot of really an incontinence program. When we treat our patients who have a certain type of incontinence, we are working on stimulating their pelvic floor muscles. Muscles of the vagina are very much any other muscle in the body. If you can isolate them and tone them, you get more control over them. Well, when we were starting to do this, it turned out that working on those muscles helped women as far as orgasm were concerned. So a company called In Control, which manufactured the device that we use for incontinence patients, took the same technology a step further. They created intensity. It sort of looks like a vibrator, and I'll show you a picture in a moment, but the technology, the circuitry is entirely different. It is designed to work on stimulating the muscles of the pelvic floor, and as well as toning them and helping women achieve vaginal orgasms, even in women who really have not experienced vaginal orgasms in the past. It's the only device around. It may look like a vibrator, but it is not. And this is what it looks like. It basically has circuitry in it that's the toning and stimulating the pelvic floor muscles. You can obviously stimulate the clitoris, although you can turn it on or off. You can decide whether you want to add the clitoral stimulation or not. It's the rest of the device that is really working on toning the vaginal muscles. Basically, it allows a woman to be totally in control. Once it's placed in the vagina, it needs to be inflated because you need to have the electrodes touching the vaginal walls so that you get the proper stimulation. You actually want the muscles to be in contact with the device. You can, with the device, obviously stimulate the G-spot and the clitoris at the same time. There are 5 different levels that you can set the thing to. So between not just the muscle stimulation, but also the clitoral stimulation, it comes out to 10 different levels of stimulation. So basically, you're gradually contracting and toning the pelvic muscles and strengthening them as well. I'll cover all that. Some of the things we have gleaned from our patients that have been using the device, which everyone has pretty much, to be honest, been thrilled with so far. You really need to have an initial instructional session with a counselor, with someone who knows what they're doing. In our office, it happens to be Jill, because
if you're not using it properly, you're not going to get the best
results out of it. It can be used with a partner, without a partner. Some people get a little frustrated in the beginning because they're not getting a good response. That takes time, especially in women who the muscle tone isn't there yet. Once you have indeed toned the muscles, the interval to reach an orgasm decreases very rapidly. You also do not want to try and remove this in the on position. What can happen is that the electrical stimulation, if it still happens to be turned on as you're pulling it out of the vagina, it will be uncomfortable once you reach the labia. The tissues of the labia are much thinner, they're much more sensitive, and if the electrical current is still turned on, it'll be really uncomfortable. So you got to be very careful about making sure you shut it off before you take it out. And the other thing that we also learn from our patients is you need to use rechargeable batteries. If not, you will go through batteries very rapidly. Very quickly, I just want to touch on one other thing, and that has to be something, a product called Vitality. Vitality is kind of an interesting supplement because it functions at the level of the cells of the body. All of our cells have something called mitochondria. Mitochondria are kind of like the fuel cells of the body. And as we get older, the mitochondria make two kinds of fuel, something called ADP and ATP. It's sort of like regular gas and high-octane gas. As we get older, the mitochondria do not make as much of the high-octane gas as they did when we were younger. What these people have managed to do is create a product that forces the mitochondria to pop out more of the high-octane gas. So what happens, and most people really notice this within a week, is that you do have a better energy level, you have really mental clarity, more focused. And the third side effect happens to be that you do have increased libido. So, like I said, the high octane gas tends to drop off as we get older. And the whole concept of Vitality really is to try and pump up and force the cells to create more of high octane gas in our older years. That's pretty much what I'm going to talk about, and then I want to turn the microphone over to my friend Dr. Tom Gionis, and I can't even list all of his certifications, so I'll let him tell you. But he's going to talk about male sexuality.